See You Now is a podcast highlighting the innovative and human-centered solutions that nurses are coming up with to solve for today's most challenging healthcare problems. Created in collaboration with Johnson & Johnson and the American Nurses Association, and hosted by nurse economist and health tech specialist, Shauna Butler.
Welcome to See You Now. I'm your host, Shauna Butler.
A public health nurse, their primary focus is on the community of Anchorage or the community of Bethel. And we expand that responsibility for good health beyond that individual or the family. And instead, we focus on the community and the environment that surrounds them, looking at housing, employment, food security, access to education. Those are the things that if we work with community partners to help make sure that they are readily available, then we're helping that person beat the odds by making sure that those odds are working in their favor.
When we think about what a midwife does, or when we picture a nurse in an emergency department or an intensive care unit, we're able to conjure up an image of what they do and where they work. We may even have a good sense of what their day or their night might be like. But when we think about a public health nurse, that image is a bit fuzzy, and a clear picture doesn't necessarily appear. The epic stories of public health include the people, ideas, and settings where life-changing and life-saving discoveries and innovations emerged. And nurses have always had a starring role in these stories. Think of Lillian Wald and Mary Brewster, pioneers of public health nursing. In fact, Lillian Wald is credited with coining the term public health nursing. In 1893, shortly after training as a nurse, Lillian Wald, the daughter of a well-to-do and socially prominent family in Rochester, New York, began teaching hygiene and health classes to immigrant families and their children on the Lower East Side of New York City. Distressed and appalled by the living conditions, unsafe streets, and grim realities of the poor immigrant neighborhoods, she and Mary Brewster established the Visiting Nurses Service. They witnessed the often brutal relationship between poverty and poor health, witnessed the disparities that existed between neighborhoods and between their own lives and the people they served, and recognized that remedying those conditions was a matter of public interest. Their insight and observation sound obvious and straightforward, but as Diane Baker, a public health nurse from an earlier episode of See You Now said, there is no such thing as a simple solution in a complex system. And communities are complex, especially the communities with wide disparities, such as those in Alaska, where public health nurse Tim Struna practices.
We have a disparity in Anchorage of almost 20 years in terms of life expectancy between zip codes that are about a mile apart.
There are parts of the public health innovation story that Alaska portrays vividly due to its distinct differences from the other parts of the U.S. In this episode of See You Now, we talk with Tim Struna, Alaska's Chief of Public Health Nursing, about his work, his team, and responding to the COVID-19 pandemic. I started by asking Tim to introduce us, not only to him, but to Alaska, to its geography and health landscape.
My name is Tim Struna. I'm the section chief for public health nursing for the state of Alaska. I came to Alaska as a public health nurse, and over the course of the last 18 years have found myself in almost every position that we have within our section, and until about maybe 3 years ago have been in the chief position. And we've got about 160 staff members spread across the state. Alaska is a frontier state with challenges that, from a public health perspective, are not seen in many other states within the nation. We have communities that don't have running water, facing diseases that are more profound in the state of Alaska, like tuberculosis, than any other state. We have a population of about 740,000 people. And when you look at the land mass, it comes out to about 1 person per square mile. When you compare that to the rest of the nation, which is about 90 persons per square mile, it kind of gives you a little bit of a context. If you doubled the size of Texas, it would still be the second largest state in the nation. But when you have a state that's that large, you can be in Southeast Alaska. It's a rainforest, and so you're on the water, confronted immediately with mountains, snow-capped peaks, and lush forest. And then you go out to Bethel, Alaska, and it's tundra. It's flat, it's marsh and rivers. You look out your door and you can go for hundreds of miles in a straight line, and there's not much undulation in the terrain. And then you can go up into the North Slope and you have that same feel of flatness, but then you're up against the ocean and it's 50 below. And then you come into Anchorage and we have mountains, birch trees, and we're right in the middle of a beautiful fall coloring right now. And so you can have so many different experiences in terms of the environment in the state. It's a striking visual and culturally fascinating. There's over 20 distinct indigenous languages spoken by Alaska Native people. And the Anchorage School District, there are over 100 different languages spoken within that population in the school district. And so some of the work we do is through that extension of working with our community health aid partners across the state. But in higher density populations like Juneau and Anchorage and Fairbanks, we work with different organizations that have parents as teachers, helping to make sure that care that's needed for our most vulnerable families are provided, but they're not necessarily provided directly by the public health nurse. We have to work together in order to improve the health of everyone, particularly our most vulnerable. We have about 100 public health nurses spread out across 16 public health centers, knowing that there are over 200 communities that you can only get to by getting on a plane or taking a boat trip. That ability to impact at that individual level is a challenge. And so that's really pushed the public health nursing workforce to embrace our practice expectation of not only focusing on that individual, but focusing on the context, the environment, the community, and helping to make sure that there's an opportunity to make a healthy choice, and that healthy choice is the easy choice.
So where we are at this current moment with COVID and this pandemic, like other epidemics, there's been a crash course in raising the awareness of the need for good public health interventions. But I don't know that we've had necessarily a schooling to the public of what public health and public health practice is. I mean, it is so encompassing. So I know this is a real challenge, but what is public health? What is the public health practice? Because I think people really understand maternity care, they understand dental care, they understand orthopedic care. I think we would do everybody a really great service if we gave them the same clear understanding of public health.
Public health is the practice of assuring that populations have what's necessary to reach their full potential in terms of health outcomes. And so from a public health nursing lens, that difference between like a nurse working in the emergency department where your immediate focus is on that individual that's right in front of you, a public health nurse, their primary focus is on the community of Anchorage or the community of Bethel. And we expand that responsibility for good health beyond that individual or the family. And instead, we focus on the community and the environment that surrounds them. Public health nurses work at the community level, looking at housing, employment, food security, access to education. Those are the things that if we work with community partners to help make sure that they are readily available, then we're helping that person beat the odds by making sure that those odds are working in their favor. One of the analogies that I've used is if there's two individuals in Anchorage living in two different zip codes, both with a diagnosis of diabetes, they both are given education about eating healthy and getting exercise and taking their medication. And all of those things are helping them to beat the odds of that disease so that they can live a healthy life. But there are folks in Anchorage in a particular zip code where there is not easy access to fresh fruits and vegetables. There isn't easy access to parks or sidewalks that have street lights so that they can go for a walk or a jog in the middle of the winter when there's only 4 hours of daylight. Those are the things that the public health nurses are thinking about and working with community leaders so that we can change the odds of the folks living in a particular zip code to also lead a healthy life. And we have a disparity in Anchorage of almost 20 years in terms of life expectancy between zip codes that are about a mile apart. How that plays out with the pandemic responses, again, when we look at Alaska, if we tease out that wash your hands message, that's great. And that's going to help someone keep themselves from getting sick. But we have communities here in Alaska where there isn't running water. And so we need to be mindful of the education that we're delivering and whether or not that information is actionable.
How healthy are Alaskans and how are they staying healthy?
When you look at, the top 10 causes of death in the state and you compare that with national metrics, heart disease, cancer, those are in the top 3 nationally, and those are the same in the state of Alaska. But what I think is profound is that our 5th leading cause of death is suicide. And when you look at suicide, and it's sort of defined as deaths of despair, when you look at the population density, that isolation factor is a contributor. But then when you also think about those underlying conditions and that historical trauma, that's a profound impact on the health of Alaskans.
Can you say more about the historical trauma? What does that mean? What is that experience?
That's a long story. When we were putting together our contact tracing workforce, it was originally held within the public health nurses and the section of epidemiology. But we knew at the beginning that we had to figure out how to expand the workforce beyond our section. And so we put together a contact tracing training that would be available to folks outside of our section. And we took the CDC national guidance and their questionnaire, but we knew that we had to incorporate some additional components to that training. And one of the pieces that we specifically focused on was historical trauma. The 1918 flu wiped out a significant proportion of the Alaska Native population. And so in this pandemic today, there's a significant fear across the state that if the disease makes it into some of these rural communities where there's a lack of transportation to a higher level care facility, the lack of ability to really move someone successfully into isolation and quarantine is significant. And so we incorporated that into our training so that there was that recognition of what that phone call would have on someone in a village. We know that when we fly into a village and we bring a bag full of vaccines or tuberculin syringes because we need to do a tuberculosis screening sweep of a community, that it wasn't very long ago that there were nurses and physicians flying into villages and taking people away and putting them into the TB camps and out of the villages. And there were kids that didn't have their parents the next day because of the extraction of individuals that were positive for TB. And so everything that we do when we're in a village has to be embedded within this traumatic historical experience that folks have had. And the way we conduct ourselves is going to have a profound impact on the success. Missteps are going to cause significant harm. Mm-hmm. Trust and having positive relationships with the public health nurse and anyone within our division of public health, it's the one thing that if it is not in place will lead to either the success of an initiative or the sinking of an initiative. And we know that, if we are going into a village or if we're on a Zoom call with the community and we're talking through, okay, so what might happen if you find a case in your community? We can't go into those conversations with the assumption that we have the answers and we need to be feeding this to the community. We have to go into these discussions as partners, mutually benefiting from each other's knowledge and wisdom as compared to we have all the answers, you need to do what we say. That's part of our orientation from day one with public health nursing here in the state of Alaska. If that positive relationship and development of trust is not in place, it will make or break the community's response to a public health issue.
Building on that experience of what you've had to do with other outbreaks, going into the communities to do a rapid vaccination program, what have you learned from that we can apply in COVID and innovate off of?
Yeah, what we have found, it has to be viewed as an equal partnership. And that's really what we continue to try and build as the standard practice, is moving away from the swooping into a village and stirring things up, taking control and screening as many people as we can, and then looking at the results and then getting on a plane and leaving, to before we even arrive in a village, there's a lot of conversation with tribal leaders, city council leaders, the health corporation, the health aides, talking about what needs to happen, explaining the why, talking about what are some things that we might want to do to address that historical trauma. And so the way that a TB sweep looks in each community is going to be different, and it's going to be driven by the local community leaders. The way we conduct the screen is going to be the same, but how we conduct ourselves when we get off of the plane is going to be different, and it's going to be driven by the local community swooping in and taking care of things, and then getting on a plane and leaving is not going to be our best approach.
In addition to addressing COVID and thinking about the testing, all of our other non-COVID related health services have needed the same attention that they needed before. I mean, none of those went away. So how have you guys been able to address some of the ongoing challenges? I'm thinking about smoking cessation, safe and healthy pregnancies, other communicable diseases. I mean, have you pivoted? Are there things that you're doing differently and innovatively to continue other public health needs?
That's a painful answer to the question, because infectious diseases like tuberculosis, we have not stopped. But all of the kind of the other things that you had mentioned, we've had to put aside. We are working with our state leadership to come up with ways of streamlining our hiring process. So it's not really a practice that we're really looking to innovate. It's more, how do we open the door for registered nurses that are interested in supporting our response and get them on board so that our public health nurses can kind of step back from the contact tracing and start picking up some of these pieces that have had to fall off the plate because of our capacity challenges. Once we get through this, there's an opportunity to pick up the pieces and maybe build up Alaska's health response around the conditions that we know are driving our poor health outcomes in a way that maybe was not done before. So the opportunity to innovate as we move back to normal, it's just on the horizon. And how do we build up the health delivery system and the social delivery system so that we are focused on the things that we know are significantly impacting the state. And so there's opportunities to innovate down the road, and we are building our workforce to help facilitate that. Mm-hmm. But right now, focusing on things other than the pandemic it's just not our reality today, unfortunately.
Talking about the role of trust. Nurses are so key in those trust dividends. When you think about how we need to innovate in building trust, have you got some ideas about how we might innovate to increase the speed of gaining trust or the score of trust?
Yeah, that's interesting, because can you build trust quickly? I think you can. What we've been building into our contact tracing training is the significance of having effective listening skills. Again, not coaching someone to wash their hands every hour if they know they're talking to someone in a home where there isn't running water. And we need to be able to pick up on those things very, very quickly. We need to be able to pick up on the tone of the individual that we're talking to. And we need to be mindful of, again, that historical context and that historical trauma. And if we can put all of those pieces together, which is what we're trying to do for our contact tracers, then we will continue to have a successful interaction between the individual and the contact tracer. Right now, it's not a vaccine and it's not a treatment. The intervention is isolation and quarantine, and that's a behavior choice for all of us. And the quicker we can establish that trust and that relationship, then hopefully the quicker someone will take that action of making that behavior choice to stay in isolation or to stay in quarantine.
You had mentioned how many different languages there are. And a big piece of building trust is feeling seen and feeling known and being understood. How are you using those language differences to share with people, I know you, I understand you, I respect your language, I encourage it? Are you using that in your contact tracing to help people feel understood?
We have a language line service, and so every contact tracer across the state has that number, which we call, and we've used that very heavily. What we've found to be very useful from having that language line is that we can get a report to find out which language has been used most frequently. We are then in turn using that information to make sure that our public messaging is focusing on the languages that we're finding we're having the most conversations with individuals that are testing positive. So it's helping us to drive our public messaging across the state.
Are there any technologies that you're using to help with the contact tracing?
The electronic health record that we're using to specifically capture our contact tracing efforts does have a texting feature. And so we are in the process of building that so that we can send a text to folks daily that are going through quarantine. And we're using that language line information to make sure that the texts that get sent are in the languages that we know are making up our cases and contacts. So that's something that our public health nursing informatics team has been working with the developers of our EHR for a couple weeks. When we started this, we were using Excel files to track our cases and contacts, and we came up with a way of creating a shared Excel file that all 16 public health centers spread across the state would have access to. And that was able to get us probably up until like April. And then we knew that that system was going to be overloaded. And so public health nurses, our nurse consultants, went through a rapid process with our security team and our IT team to identify a solution that was going to have the capacity to scale up to the case counts that we're seeing today. And that was nursing driven. So to a degree, we are going through that rapid plan, do, study, act cycle. Every morning, take a look at where are the gaps, where are the bottlenecks, and what do we need to do differently today. Every single day, all day long, in trying to make sure that we're keeping ahead of the disease and the nursing process. It's a beautiful thing, and it's a beautiful thing to see that unfolding every day. It's a struggle for all of us, but that is something that's kept us from sinking. From the beginning, there was discussions with the state, with our tribal health partners, about how are we going to make sure that there's an equitable distribution of these limited resources. And as the healthcare infrastructure, particularly through our tribal health partners, grew, the public health nursing workforce had to grow also, and we grew into this population-focused practice. If our section had not done that and didn't have the necessary knowledge, skills, and abilities to successfully work at a policy level with our emergency operations center partners, our state would probably be worse off than it is today, because our public health nurses have the skills to work one-on-one in a contact tracing venue and learn from those experiences about conditions that are preventing folks from being successful during their isolation and or quarantine time. And instead of our work sort of ending there, the public health nurses also have the knowledge, skills, and abilities to take that information, that story that they're hearing from the client, and packaging it in a way to mobilize partners, to influence policy, and to build the resources that are going to help keep those vulnerable populations successfully isolating and quarantined. That's like a cycle. The individual is feeding the community focus, and the community focus is then feeding the clinical focus. The fact that our public health nurses can navigate those two worlds successfully has created additional protection for Alaska that I don't think would have been in place 15 years ago.
As you're painting that picture, we have had this understanding of public health nurses being the ones who are the front line direct caregivers. So whether it was dental care, immunizations, seeing a new mom, that is a core competency. But when you move nurses up into that policy level, figuring out how we're going to fund this and distribute it, we can, instead of taking care of the few people that are in front of you, you can take care of a population that's spread across this vast state of Alaska, or vast territory that any public health nurse might find themselves in.
My favorite phrase from the ANA Code of Ethics is that ethics, human rights, and nursing converge as a formidable instrument for social justice and human rights. Public health nurses, particularly, and I know I'm probably biased, we are a powerful tool to actually operationalize that statement from our Code of Ethics. So I'm glad you brought that up, because that's why I'm in the work that I do, and I think that's why all the public health nurses in Alaska are doing the work that they do. You know, everybody's exhausted, working 7 days a week, some folks 12 hours a day, and phrases like that just keep us one step at a time, leaning into this pandemic And it's amazing to see the folks show up every day and do everything they can.
Tim Struna is the Chief of Public Health Nursing in the Alaska Department of Health and Social Service, where he is busy coordinating health services in rural areas to increase access to residents, particularly during COVID-19. He has delivered care and testing services to patients located over 3,000 miles apart with limited to no road access. Tim and his team work with 16 public health centers and tribal health organizations to coordinate the needed care and response during COVID-19. At the core of public health, there is the principle of social justice, that people have the right to be healthy and live in conditions which support their health, where they have things like clean air and clean water, safe roadways, safe food supplies, the prevention of communicable and non-communicable diseases, and access to care. This social justice principle has put the public health lens on topics such as smoking, obesity, traffic safety, workplace safety, and disaster preparedness. When done well, public health is somewhat invisible. Nobody pays attention to the crisis that didn't happen. But during a public health crisis, like right now, we are unfortunately and distinctly aware of the connections between social justice, public health, and innovation. In listening to Tim's story, it is satisfying to hear the attention he pays to the past missteps of public health practice in order to not repeat them. It's also exciting to hear and learn how public health nurses are innovating to respond to the unique challenges of our current public health crises. Yet, at the same time, it is a bit painful to know that we don't have the resources required to address all public health matters simultaneously. We have to prioritize. Some public health initiatives that don't have the same urgency will not get the attention they need and deserve. It's important that we hear these stories and acknowledge where the cracks are, especially during this crisis. The cracks, as Leonard Cohen said, are where the light gets in. And that light can guide us as we decide where to invest our innovation efforts. As Tim shared, a lot of what we do in healthcare delivery is focused on helping people beat the odds to overcome poor health. But with a robust public health practice, we are innovating to change the odds, ensuring the conditions in which people can be healthy and live healthy lives. For See You Now, I'm Shauna Butler. Thanks for listening and stay healthy.
Johnson & Johnson is proud to power up nurse-led innovation that is transforming health outcomes through skill building, leadership development, and more. The American Nurses Association ignites and celebrates nurse-led innovation to redefine quality nursing and advance healthcare for all. Subscribe to the podcast and learn more at seeyounowpodcast.com.